So the first talk I want to talk about is presented at EHA this June with the virtual EHA, which is fantastic. So it'll be presented by Matt Wilson on the special lymphoma question and answer day on the 21st of June and available on the website. So this is looking at the impact of high-dose methotrexate used as CNS prophylaxis in patients with diffuse large B-cell lymphoma treated with R-CHOP. Now, we know that secondary CNS lymphoma, as I said before, has a dismal outcome. We do all we can to prevent it. So historically, we've used intrathecal therapy, but more recently, we've tried to use high-dose methotrexate. We know that secondary CNS lymphoma tends to occur early. Studies have shown that the median time to present with secondary CNS lymphoma from diagnosis is around 5 to 8 months. So it's something we need to think about at presentation, and we have to think about how and when we're going to give CNS prophylaxis, really as we commence therapy. So Matt Wilson with Pam Mackay from Glasgow initiated a study. It's from 11 centres in the UK involving more than 300 patients and comparing the outcome of patients receiving high-dose methotrexate intercalated during R-CHOP courses and a cohort of patients that they were compared with who received high-dose methotrexate at end of therapy. So the two cohorts of patients were relatively similar. The very high CNS IPI was actually in a higher proportion of patients who received end of treatment high-dose methotrexate. That's partly because of a poorer performance score in that cohort, but also a higher proportion with renal and adrenal involvement. Now, an important point was that 60% of patients received concomitant IT therapy in those who had end of treatment high-dose methotrexate, while that was only in about a third of patients who had intercalated high-dose methotrexate. So that may or may not be important. So we looked at different outcome. We looked at potential delay of delivering R-CHOP, as well as other outcome measures of PFS, overall survival, and of course, CNS relapse risk. Other outcomes such as mucositis and neutropenic fever were also measured. What our study showed is that in 20% of those high-dose methotrexate courses, when given intercalated, they were associated with delay of delivering R-CHOP, and the median time was around 7 days. Now, if you delivered high-dose methotrexate before day 10, that seemed to be a reduce in reduction of delay in delivering R-CHOP, and at UCLH we deliver it on day 8. And certainly this data, it gives me some caution, but we will continue to do that from cycle 2 in our patients with high CNS IPI risk. So the important other measures of progression-free survival, overall survival, and CNS relapse risk were not different. They were very similar in both arms. So we have 204 patients who received intercalated high-dose methotrexate, 130 who received it end of therapy, and the important things are that 60% of the end of treatment cohort received ITs, 36% in those who received intercalated. So where does this take us? I think it's really helpful data. I think we have to be cautious how we interpret it. We have to say that we can't give everyone end of treatment high-dose methotrexate and give none of them concurrent ITs, because I do think early delivery of CNS prophylaxis is important, but certainly it's really helpful data because giving intercalated high-dose methotrexate has potential sequelae, potentially delaying R-CHOP delivery. There was also an increased risk of neutropenia and mucositis. And the important thing is just really thinking about it in a patient directed way. And I think this is helpful data and we hope to expand it.